Welcome, and thank you for joining the Scleroderma Foundation's Patient Education Summer Series. Today's talk, What Do Your Dentists and Your Physicians Want to Know About Scleroderma, Oral Health, and You, is our seventh event as we host our virtual university. My name is Kerry Conley. I am the Director of Programs and Services for the Scleroderma Foundation's National Office. We are delighted to have today's speaker, Dr. David Leader from Tufts University School of Dental Medicine, joining us today. Oral health is a vast subject to cover, and I know it's going to be a jam-packed hour, so let's get started. First,
Hi,
some
everyone. Sorry.
quick notes on today's event. If you are properly logged into today's webinar, you should be seeing Dr. Leader on the screen. Say hello, Dr. Leader. On the screen and hearing my voice. If you have dialed into the event by phone, please turn the computer microphones down to avoid any sound feedback. Today's webinar is being recorded and will be made available after its broadcast. The Scleroderma Foundation in no way endorses any drugs, treatments, clinical trials, studies, products, or devices referenced in today's webinar. Information is provided to keep the listeners informed. Because the manifestations and severity of scleroderma vary among individuals, personalized medical management is essential. Therefore, it is strongly recommended that all drugs and treatments be discussed with the individual's physician for proper evaluation and treatment. This webinar is for educational purposes only. We encourage all attendees to use the chat feature opportunity on the sidebar. Team members for the national staff will be hosting a question and answer segment at the end of the presentation. Please note we will do our best to answer everybody's questions. So let's get rolling. I am delighted to introduce today's speaker, Dr. David Leader. Dr. Leader is the Associate Professor of Comprehensive Care at the Tufts University School of Dental Medicine and the Associate Professor of Public Health and Community Medicine at the Tufts University School of Medicine. For his incredible contributions to the scleroderma community, he was recognized as the Scleroderma Foundation's Doctor of the Year in 2008. Dr. Leader will speak on how scleroderma affects your oral health and the information that your dentists and your physicians need to know about how they may help you maintain and improve your oral health. Thank you for joining us today, Dr. Leader.
Carrie, thank you very much for having me. And thank you, Carrie. Thank you, Angel, all the support staff at the Scleroderma Foundation. And let's get on with it. And thank you all for being here. So I'm very sad that we're not able to get together this year in, it was supposed to be Seattle, right? But here we are on the other coast in Boston. This is my school. The very important people at my school have offices on the top floor here, the 15th floor. So all of the deans and the research department is here. Public health is over here. The higher up you are in the building, the more important you are. My office is, oh, you can't see it, but it's on the second floor way down here. And I am talking to you from my home in Gloucester. And this is Boston. Here's Cape Cod, and Cape Ann is this little island off of the northeast corner of Massachusetts, and I am located on the river that separates Cape Ann from the rest of the world. That's the river, the Annisquam River. This is the bridge in the background that goes to Boston. So welcome to my home, welcome to my boudoir. And let's talk about what your dentist and your physician would like to know about scleroderma and oral health so that we can help you. So first of all, this is a picture of me in a panel discussion not far from here in Peabody, Massachusetts, 6 years ago. And I am sitting here at the table with rheumatologists, with gastroenterologists, and with a basic science researcher. And this is what all of you should have when you're talking with your advisors about your care. You really need a team to approach your condition, to approach this disease, and everyone needs something different. So what does the team need to know? Because I just want to point out, About 80,000 people in the United States have systemic sclerosis. That does not compare to the number of people who have things like lupus erythematosus, rheumatoid arthritis, other autoimmune diseases, diabetes. So we do all learn a little bit about scleroderma when we're in school, but really only a small amount. And then, because there are so many dentists and physicians and so few people who have scleroderma, I'm 60, I could have gone my entire career never having seen a patient who had scleroderma. And I hear that all the time from other providers. So it's important as a patient for you to be self-promoting, for you to come in, know the kind of information that your team needs, and help them get that information so that we then know how to help you. And you need to find providers who are open to that, providers who are interested in that, providers who want to learn and want to be able to help you. And we do all have the skills, the skill set to help you. We just need to know what to do. So the medical team, first of all, knows very little about dental issues. Even at Tufts University, where we have the second largest dental school, and our medical students get more education in oral health than maybe any other medical school in the world, they still only get about 6 or 8 hours of lecture on oral health. So they need to know what the oral health issues are that are associated with scleroderma. They need to know how a non-dentist will recognize these problems and what systemic healthcare professionals can do to help you. They may need to know how to refer someone who has scleroderma to a dentist, because not every dentist is going to be knowledgeable of scleroderma and know how to help you. Although I'll talk with you about that shortly. Also, sometimes it's helpful for a physician to write a letter to your medical insurance and work out with your medical insurance a way that they might be able to cover your dental care because your oral health is affecting your systemic health. Now, what about the dental team? What do we need to know? We need to know things like, what are the oral health issues that are associated with scleroderma? How does scleroderma affect your systemic health? Because we need to know about your systemic health. We need to know who your physicians are so we can get in contact with them if we have questions, and also so we can advise them so that we can have this dialogue that I'm talking about. And we need to know how we can work with your medical team. What kind of information does the medical team need from us? And what can we expect from them? Dentists, we know about dental insurance very well, but we do not know about medical insurance. Most dentists have nothing to do with medical insurance, and the few that do are primarily oral surgeons. So an oral surgeon might be helpful dealing with a medical insurance company, but the dentist who sees you for your checkups and to make your crowns and dentures, no idea. And we need to know how scleroderma affects dental implant treatment and orthodontics. And I'll talk about the dental implant treatment. The orthodontics, people who have scleroderma can have braces, and it usually works out fine. And unfortunately, that's all I can say about that right now. So how does scleroderma affect your oral health? Scleroderma causes you to have dry mouth, either by the disease itself. So about 70% of people who have scleroderma have dry mouth. And by the way, many people who have dry mouth don't realize that their mouth is dry. They might walk around with a water bottle, taking sips of water all the time, or they might be sucking on candies all the time because their mouth feels dry, but they may not equate that with the disease or realize that it's an unusual problem. Scleroderma has interesting and unusual and deleterious effects on your teeth and on your bone. So it can cause osteolysis, or resorption. Osteolysis is where cells start to eat away at the bone, and resorption is where these same cells eat away at the bone and eat away at the teeth, and we'll talk about that. Pain and difficulty opening your mouth, and sclerodactyly, where it's hard to open your hands and it's hard to grasp things. Oral effects of medication. Some of the medications that you take are helpful to you in one way, but can have side effects that are harmful in another. And then the psychological effects of having a systemic chronic illness, which for many of us would make it hard to do your activities of daily living, which include brushing and flossing and getting to the dentist. And then gastroesophageal reflux disease. And many people who have scleroderma have terrible unremitting gastric reflux, where stomach acid comes up through your esophagus and gets in your mouth and causes damage to your teeth, causes tooth decay, and also if you inhale it, causes damage to your lungs. Dentistry and scleroderma go way back. So this is an interesting radiograph. It's from one of my patients that I took a long time ago. Unfortunately, he has since passed. But this is a man who had scleroderma. And when a dentist looks at an image like this, an X-ray image or a radiograph, we are looking for, I'm going to enlarge this, for this white line to be very close to the tooth, like it is on this side of this tooth. But you can see that on almost all of his lower teeth, there is a widening of this space in between, which we call the periodontal ligament space. So the teeth are held into the bone, not by bone, but by a ligament. And when you have scleroderma, many times that ligament will become enlarged. And practically what that does for you is it makes your teeth feel loose. So some people who have scleroderma and widened ligament space that looks like this, they feel their teeth are wobbly when they're chewing, or they can actually take them with their fingers and move them. And when a dentist sees this, if we don't know about scleroderma, if we don't remember that very brief discussion that we had when we were in our second year of dental school, or that single paragraph in Bashkar's 1981 synopsis of oral pathology textbook, then we may think that all you have is a bad case of gum disease. And we may want to do gum surgery here, or we may want to extract these teeth because of how bad the gum disease is. When in fact, this gentleman's lower teeth are not bad. He's lost some bone in between the teeth, but not a whole lot. Even though this tooth is wobbly, it can stay there for a long time like that. Now, his upper teeth happen to have very bad gum disease and needed to come out, and he needed a denture. But the lower teeth he could keep for a long time. Interestingly, a research group in, so this opening, this widened periodontal ligament space on so many teeth is pathognomonic. That's a word that means you see this pathology, you know that it means that the patient has scleroderma. And in that way, a sharp dentist might be able to diagnose that you have scleroderma even before your physician realizes it. And I've actually seen that happen. Now, something that's kind of interesting is a Canadian group, and actually I think Carrie was the one who sent me this paper. A Canadian group found that the more of this widening of the periodontal ligament space you have, the worse your scleroderma is or will become. And I met one of these authors when I was giving a lecture in Portugal a few years ago. So let's see. Dentists, when we look at our patients now, we are looking at your risk for tooth decay. And we look at different aspects. How many cavities do you have? What are you eating? What is your health like? So, and sometimes we use a system called CAMRA, or Caries Management by Risk Assessment. So we look at all these risk factors and we check off how many risk factors you have. And does the patient have special care health needs or special health care needs? Does the patient have 3 or more cavities in the last few years? Does the patient have teeth that are missing because of tooth decay? Does the patient have severe dry mouth? Does the patient have medications that reduce how much saliva they have, or visible plaque because you're having trouble cleaning your teeth, or exposed root surfaces because the gums have receded, or do they have trouble finding a dentist to take care of them? If you have any of these risk factors, you are high risk. If you have multiple of these risk factors, you are extreme risk. And really, anyone who has scleroderma who's watching this, you are at least high risk because you have special healthcare needs. You probably have severe dry mouth, although you may not, and you may be taking medications that reduce salivary flow. You may have other of these risk factors too, but you need to be treated like you have high risk, which means that you're going to need to come to see the dentist or dental hygienist more frequently, more than every 6 months. You're going to need a prescription for a stronger fluoride toothpaste, which we'll talk about in a minute. And good job brushing and flossing, watch your diet, stay away from soft drinks, that kind of thing. So what about treatment of xerostomia? There's a few different ways to treat xerostomia. Primarily, the treatments are symptomatic. You know what? I just realized, oh, here's my watch, good. I thought I had left my watch somewhere. It's primarily symptomatic. So we see patients come into our practices all the time who are carrying a bottle of water with them. They always have a bottle of water with them. They can't leave the bottle of water out in the waiting room. They have to have it with them. They have to sip on it all the time. They're always asking to rinse their mouth while we're working. That's a really good sign. We call that the water bottle sign. But that's a good way to treat your xerostomia, just constantly hydrating. Also, we can prescribe a mouth rinse called Cafisol. And by the way, I do not have any interest in any of the medications, mouth rinses, devices that I'm going to talk about, but Cafisol was developed at Tufts University by one of my mentors who is an expert in Sjogren's syndrome. She also developed Salivart. I'm sorry, not Salivart. She developed Salagen, which is Pilocarpine. She was studying Pilocarpine for some other reason and found that it made people salivate more. And so that's the only link that I have to any of these products. And none of those links are financial. So Cafisol, which is a super saturated calcium phosphate rinse, artificial saliva like Salivart, Oasis, Biotine rinse. These artificial saliva rinses are only to make you feel more comfortable. Cafisol actually does something in that it helps remineralize teeth. Sugar-free candies, that you can suck on those and it makes your salivary glands work harder. Fluoride, lots of fluoride, that's very helpful for hardening your teeth and making them more resistant to decay. And also I'm going to show you a new fluoride compound, or relatively new in the United States, that actually hardens up tooth decay. And I'll show you how that works. Also, we can prescribe a chemical that acts on the nerves that go to your salivary glands and convinces your salivary glands to produce more saliva, even though the salivary glands aren't working as well as they used to. And this is Salagen and Evoxac, or Pilocarpine and Cevimeline. So we'll talk about that in a minute. Here's Cafisol. It comes in these, it's a liquid. It comes in these blue and white tubes. You mix one of each together into a cup. You rinse with half on one side of your mouth for a minute, spit it out, then rinse with half on the other side of your mouth for a minute, spit it out. Do not save it once you've mixed it, because after 15 minutes, all the calcium precipitates out and it's no good anymore. You do need a prescription for that. You need a prescription for this too, for the higher concentration fluoride toothpaste. So regular Colgate fluoride is 1,500 parts per million fluoride. The prescription fluoride toothpaste is 5,000 parts per million. I always prescribe Prevident 5,000 plus, sort of like you would tell someone to go get a Kleenex, but I always put on it that it's okay to substitute with generic. And interesting, somehow Colgate worked out something where in states where generic substitution is required, for some reason with Prevident, you have to put in the prescription that you are approving the substitution for a generic. They somehow convinced the FDA that Prevident is in some way different from every other generic product, which it isn't. Fluoride varnish. Fluoride varnish is even more concentrated fluoride. When you come to the dental office and we clean your teeth right then, we can apply fluoride varnish onto your teeth, and then you leave it on for several hours. And it's a very effective fluoride technique to help prevent tooth decay. So these are, right now we're talking about ways to prevent tooth decay. Although using fluoride varnish and using the stronger fluoride toothpaste and using Cafisol can actually reverse the where cavities are starting, where it's not cavitated yet, but where the tooth is becoming soft. Now I want to show you a video from Tufts. So this is something that's relatively new, silver diamine fluoride, which is the strongest application of fluoride. I'm sorry, I just stopped it. Now, would someone in the chat please tell me if you can hear this? Because there's beautiful music in the background.
We can hear it.
Oh, good, thank you. So this is a video that we use to teach our students how to apply silver diamine fluoride for their patients. So silver diamine fluoride is actually produced as a desensitizing agent for teeth, but we're using it off-label to stop tooth decay, not to fight tooth decay, not to prevent tooth decay, but to stop it. It's important that we inform the patient that there are certain effects of it, like it's going to stain your teeth everywhere that there's decay. It's very messy, it's very stainy. The stains on the teeth will be there forever, but only where you have a cavity. This is Dr. Killar. She graduated first in her class about 10 years ago from the dental school, and that's one of my new graduates. He's now practicing somewhere out west. So when it stains your gums, it only stains for a couple of weeks if we get it on the gums. I haven't had anyone complain about this, by the way. And we only use a tiny amount. 5 drops is enough for your entire mouth. So where you have tooth decay that is so obvious that we can see it, we can paint the silver diamine fluoride on it like we're doing on these extracted teeth, and just leave it there, and it turns the decay hard and black. And then the tooth just stops decaying. And then later on, after a week or two, we can put a filling over it so that it doesn't look so dark. Being very careful to throw things away and not get the silver diamine fluoride on the floor. No eating or drinking for 30 minutes to an hour after we put it on your teeth. and we want to put it on 2 or 3 times a year. All right, I think that's enough. I hope that was fun. So that's a little bit of dental school for y'all. Now, what about these medications that make you salivate more? Can they work? Yes, they can work, and they do work, and I prescribe them fairly regularly. Just a few things that you have to know about them. It takes 6 weeks to notice any kind of improvement, and it takes 12 weeks for it to reach its full level of improvement. You have to be patient. One of the complaints that I've heard is that it takes so long that patients will double up on the dose to get it to work faster, and then they have problems with the side effects. And the main side effect is that it makes you sweat a lot, which is very uncomfortable. I haven't had any of my patients complain about sweating too much, but I've been very careful to make sure that they use it as directed. And then there are some contraindications, so it's important that your dentist and your physician work together on this. If you have uncontrolled asthma, you probably shouldn't take it. If you're allergic to the medication, no. If you have certain eye problems like acute iritis or narrow angle glaucoma, this is not a good idea. One of my recent graduates, who is now an oral surgery resident, Craig Holliday, and I just want you to notice his last name. If you remember Doc Holliday from the gunfight at the OK Corral, Craig Holliday is a direct descendant of Doc Holliday's brother, and grew up in South Carolina, whereas Doc Holliday grew up in North Georgia. And he did this wonderful paper where he reviewed charts of patients to look at their experience with Cevimeline versus Pilocarpine. And what he found was that they were both effective, but that there were more side effects. Patients noticed more side effects with Cevimeline. And a lower adherence rate. But what I pointed out to young Doc Holliday is that Salagen is an older medication and may be associated with older treatment modalities for autoimmunity. So if some of these older medications had worse side effects, and it could be that patients were conflating the side effects of the medications they were taking for autoimmune disease with the side effects of pilocarpine. And in my experience of prescribing pilocarpine and Cevimeline to patients, I am not noticing a difference between the two. Although if a patient tries pilocarpine and it doesn't work for them, then I will prescribe Cevimeline. And the reason I use pilocarpine first is because it costs less, because it's an older medication. Gastroesophageal reflux disease. Of course, this is an effect of scleroderma and its effect on your esophagus. It causes severe damage to your teeth. This is a young man who does not have scleroderma, but his teeth are all worn flat, and they're not actually worn flat because this area of the tooth, on the tongue side of the teeth, the bottom teeth don't touch there. This is just from the stomach acid running along the teeth. And by the way, this young man was sure that it was the tooth grinding that was causing all this, even though I pointed out to him there's no way he can grind some of the areas that are eroding. So that's one issue. Here on this photo, what I tried to capture was that the silver does not erode away as fast as the tooth. So it left the silver fillings very, very high compared to the tooth. And also, that's another thing. Some of my students have pointed out to me that they've done some research in scientific papers and found that if you have acid reflux, it is better for you to get silver fillings than tooth-colored fillings because the metal ions in the silver fillings actually counteract the effect of the acid. And here is a patient who came into my office, had a lot of fillings done, and then a year later had more erosion here and had another cavity here. So for gastroesophageal reflux disease, the physician, the dentist, the patient need to work together. We need to treat this aggressively. I've seen that sometimes physicians who aren't aware of what's going on with this and how it's affecting your teeth feel that patients can stand a little acid reflux, not a big deal. But if you have scleroderma, it can be a very big deal. And if you're inhaling the stomach acid, what it does to your lungs with scleroderma can be really awful. We need to raise the head of your bed 6 to 8 inches. And that means put something, books or bricks or whatever, under the feet at the head of the bed, not using a wedge pillow. Because if you use a wedge pillow, as one of my gastroenterologist friends pointed out, you can roll off the pillow and then you're sleeping on a flat bed again. So just raise the whole bed. And it's nice to sleep like that. I've done it. I have gastric reflux myself, even though I don't have scleroderma. Medication, they're going to primarily recommend proton pump inhibitors, which had a bad rap a few years ago because of small findings in big studies. But proton pump inhibitors are relatively safe medications which have an incredibly positive effect on gastric reflux. So considering that you have a tiny chance of having a problem with the proton pump inhibitor and a huge risk from the gastric reflux, you should take the proton pump inhibitor. H2 antagonists are antihistamines that are special antihistamines that reduce stomach acid. They're very effective as well. And then antacids like Tums and Maalox, they're very good. Just make sure to use sugar-free ones. For your diet, consider consultation with a nutritionist, but you have to cut out acid. You want everything low acid. You have to avoid things like tomatoes and tomato sauce. It's awful. You have to avoid peppers. No caffeine, nothing for 2 hours before bed. Stay away from any kind of fizzy drink because the fizzy drinks are very acidic, which is bad for your teeth and your stomach. And also the pressure from the fizziness can cause more gastric reflux. And you probably will need endoscopy. They put a camera into your esophagus so that they can see the lining to rule out Barrett's esophagus, which is a damage to the lining of the esophagus from gastric reflux. You can have oral effects of medication, including there are over 425 medications that cause dry mouth as a side effect. There are a few medications that cause gingival hyperplasia. You may be using some of them. A very common one is calcium channel blockers. So this would be like nifedipine, which a lot of people take because it opens up your capillaries in your fingertips and in the tips of your toes. And it also causes your gums to swell. Your gums will swell less if you do a really good job with your brushing and flossing, but they will still swell. And if they get swollen enough, the treatment is for a gum specialist to carve away, and this sounds much worse than it is, but to carve away the gum tissue that is swollen too much, and then it heals very quickly. You can have oral lesions, mouth sores because of medications. You can have the lining of your mouth be irritated or even slough away because of some medications. Candidiasis or thrush is much more common if you have dry mouth or if you're taking antibiotics that kill off all the bacteria. And there are over 60 medications that cause a change in taste or dysgeusia, which is one of my favorite words, dysgeusia. And they work 3 different ways. So they might damage the innervation of the taste buds They might damage the cells in the taste buds themselves. And also, you might have the medication, you swallow the medication, and then it gets into your saliva, and you're tasting it in your saliva. I don't know if any of you remember dimethyl sulfoxide, but it was something that people used to put on their joints back in the 70s. It was an industrial degreaser, and you couldn't do a randomized controlled trial on it because you would know if you were using it, because when you rub it on your skin, you would taste oysters. And then osteonecrosis, or bone death of the jaw, which is more common in some diseases like diabetes. It's also more common if you're taking a bisphosphonate like Fosamax, Boniva, Dedronel. If you're taking an injectable bisphosphonate, it's much more likely than if you're taking a bisphosphonate where you swallow pills like Fosamax. Also, if your oral health is poor, if you're not doing a good job brushing and flossing, you are much more likely to have this uncomfortable side effect. Microstomia and Sclerodactyly. So these are another couple of issues that affect many people who have scleroderma, although obviously not everyone. I've had many patients who have scleroderma who have perfectly normal opening, and others whose hands are perfectly normal. But it is common for people with scleroderma not to be able to open the 45 to 60 millimeters that's average for an adult, and whose hands can't grasp a toothbrush or dental floss the way a lot of people can. So for the medical team, it would be great if you see that you have a patient who has these issues to refer to a physical therapist and an occupational therapist so that they can work on how to use their hands to be able to clean their mouth better. Also remember that when you have scleroderma and it's affecting your mouth, you lose the self-cleaning of your teeth. So you can pack food in up around under your lips, under your cheeks, and you can't use your tongue to clean it away. And for the dental team, we can alert the medical team when there are problems that interfere with the activities of daily living, including self-care and eating. So we can be in touch with the physician and say, hey, by the way, this patient has sclerodactyly and needs some help learning how to brush and floss better. So it would be great if you could refer them to an occupational therapist. So for microstomia, there are a couple of things that we can do to adjust the patient, because we can either adjust the patient or adjust tools and techniques, or both. So physical therapy, and I'm going to show you a couple of exercises you can do. And then the one that nobody wants to do is commiserotomy, where we actually make an incision in the corner of your mouth to be able to access things. Usually this would be done by a surgeon when they're trying to extract teeth or put in a dental implant, but it's very unusual for this to be done. I can only think of maybe 1 or 2 cases where this was done. And it's unpleasant. It leaves a scar that you don't want. Adjusting tools and techniques. First of all, it takes a lot of patience of the dentist and the patient, because anything that we do for someone with a small mouth is going to be tedious and take a little longer. Shorten burrs. When we use the drill, we can actually cut off the end of the drill bit so that it's not as tall, or we can use pediatric size equipment. And some people who have scleroderma find that it's really good to go to a children's specialist. Also floss with a floss aid, I'll show you what that is in a minute, and take impressions with smaller or cut down trays. We've talked about, and I've looked into, using the optical devices to take impressions, and if your mouth opens big enough, it's great because you don't have to get your mouth full of goo. But if you can only open 15 millimeters, we're not going to be able to get that camera for the device into your mouth to take an optical impression. So here is my former receptionist, Shelley, showing us how to do one of the exercises. You cross your wrists in front of your chest, you lubricate your lips, and then hook your thumbs inside the corners of your mouth. We call that the commissures. And then push up with your right hand and pull down with your left, and then push up with your left hand, pull down with your right. Be firm but gentle. You're just trying to get a stretch in. Do not pull so hard that you cause cracking in your lips or damage to the corners of your mouth. It takes a long time for that to heal. And then you can get a stack of tongue depressor blades from your dentist or your physician. I'm sure that any of us would be happy to give you a handful. And each one is about 1 millimeter thick. You get as many as you can in between your teeth. You may have to use your back teeth if your front teeth are wobbly. And once you get as many as you can in between, put a rubber band around it, and then take one more and slide it in. And then maybe take one more and slide it in. And when you're getting a stretch, so not causing pain, not causing damage, just getting a stretch, just leave it there for about 10 minutes and then take it away. And then maybe do it again later in the day. Both of these exercises are a good thing to do while you're waiting for your dental appointment. It makes it easier for you and for us. And then there's these machines that do basically the same thing, the Therabite and the Orastretch. You will need a prescription from your physician to get one of these, and insurance pays for the mechanisms, and I think that you have to pay out of pocket for the replacement parts. That's old information, though I don't know if that's up to date. There are adaptive toothbrushes that you can use. I do not recommend the Dex brush, although it's an award-winning design for people who have rheumatoid arthritis. But people who have rheumatoid arthritis do not have microstomia like people who have scleroderma might have. So that's a rather large head to get into your mouth. The Benefit Plus toothbrush on the right-hand side is 3 toothbrushes that brush the cheek side, tongue side, and biting surface of the teeth at the same time. The 3 brushes are held together in this rubber sleeve, and it makes it easier to hold on to if you have Sclerodactyly because it's thicker, and then you can scrub like that. You can also use a power toothbrush, which I highly recommend. I recommend especially, and once again, I have no link to these companies at all, but the Oral-B contra-rotating head. So this is a rechargeable Oral-B with a little round head that goes back and forth very rapidly. That's what I use, and that is an excellent device, and they will last a long time. The one that I have right now, I think I've had it for almost 15 years, and I just keep getting new heads for it. The Sonicare toothbrush is similarly a very good product. I would get it with the small head. In general, adults tend to choose toothbrushes that are much too big. I see toothbrush head sizes on Oral-B that are 60s, much too big for any adult. Might be good for a horse, but what an adult should be using should be about a size 30 or 35, which when I've given those to patients before, the patients say it looks like something that a child would use, but this is the right size for an adult. And if you have microstomia, you should be using either a small adult or a large child-sized toothbrush. And make sure that the bristles are soft. And if you're using a manual toothbrush, do whatever you can to thicken the handle. You can even just wrap duct tape around the handle. When flossing is a problem for you, Waterpik makes this interesting electric flosser. You can get a rechargeable version or one that runs on AA batteries. It has little plastic tips, and it's fairly effective. I only see it for sale online now, but what I really like is this Reach Access flosser. So this is basically a toothbrush handle that accepts these little bows of floss that snap in. These are angled just right to clean between your back teeth. Very easy to use, very inexpensive. A month's supply of these floss bows costs about $5. A month's supply of these tips for the Waterpik flosser similarly costs about $5, and the Waterpik flosser costs under $20. The handle for this may be $5. Let's talk quickly about resorption. I'm running out of time. Resorption is when cells in your body start to eat away at your teeth. This is a gentleman who came to my office. He had no dental problems. He had some old fillings. He's around my age, so he was in his 50s when I saw him. He had this one area that looked like a cavity under the gum in here, not tooth decay, but from the gum tissue eating away at the tooth. So I peeled away the gum, I scooped out the tissue, I had an oral surgeon look at it under the microscope, and what he found was that the cells in the gum tissue had formed into new, bigger cells that were eating away at the tooth, called macrophages. Once you have a tooth that's being eaten away like this, it may not be possible to fix it. We tried fixing his tooth. I wasn't able to follow up with him, but I followed up with other people, and it seems that the teeth continued to get eaten away later, and all the time that we spent on it was for nothing. And I've seen cases where people spent way too much time doing root canals, crowns, all kinds of treatment for teeth that were being eaten away this way, where it just failed. So for right now, until we figure out a better way to treat this, I'm recommending that if you have a tooth that has this severe resorption, for external resorption, consider replacing it. Dental implants work well with scleroderma. So this is a case that I worked on with one of my dental school classmates, Richard Catrambone. He and his daughter are both graduates of my school, and he is an oral surgeon and his daughter is in her oral surgery residency. And this patient came to my office with this implant in place, and this tooth was very wobbly. So we had to remove this tooth and replace it. And what we ended up doing was using the same implant that Dr. Catrambone had put in years before and putting a new crown on it. This is a crown, and a false tooth attached to the new crown. And I really feel like we got a very nice result. And the patient appreciated it. So with implants, everything is on an individual basis. There's a lot of factors that determine the success. Medical history, bone quality, quantity of bone. Don't put implants in areas where the bone is being eaten away by this resorption from the scleroderma. That won't work well. Let's see. New this year, I have a couple of new things this year, and I only have a few minutes. I'm doing research with a group called SPIN, Scleroderma Patient Investigation Network. It's out of Canada, out of Montreal. And right now we are doing a scoping review of oral health and scleroderma, where we're looking at everything that's been printed for a long time on oral health and scleroderma and putting it into a relatively easy to read article. And then we're doing a survey of the SPIN cohort. And then you probably want to know what SPIN is. What's the skinny on SPIN? I'm giving you this information. I'm not going to read it all out to you, but you can go to their website, and it's spinsclero.com, spinsclero.com. So they have a cohort of people who have scleroderma. Once every few months, they send you a questionnaire that I think of as being a little lengthy, but they try and keep it down. It's usually about 30 minutes to fill it out every few months. And it gives us information on how scleroderma is affecting you, what kind of treatments you're having, what issues you're having. And we are adding in a set of questions on oral health. And hopefully we'll hear more about dental implants and resorption. And I'll be able to give you some ideas of how many people are affected by these issues and what kind of success they're having. And also, over the last few years, I've found a very tiny number of people who have scleroderma where the bone resorption they're having is in the jaw joint, in the temporomandibular joint. So the patient represented by this 3D image actually got in touch with me at one of these national meetings. And she said that she would send me this paper by Doucette and Morrison about her experience with her TMJ. And what had happened was so this is a normal TMJ, and you can see here's the mandible, the lower jaw, and it has two parts that stick up. This is called the coronoid process. Muscles attach here. And this is the condyle, and the condyle is the ball of a ball and socket joint. And the socket is part of the skull or the temporal bone. So the TMJ, or I'm sorry, scleroderma had eaten away her condyle, the ball joint, at the ball of the joint, and had eaten into the socket. And I've seen patients who have this where so much bone was eaten into the socket, the lining of the covering on the brain, the dura mater, was actually protruding through this window that was coming out of the skull in this area. And it can be very uncomfortable if you still have some of the joint rubbing there. In this case, this patient was not able to touch her front teeth together, and she also was only able to open 15 millimeters. So they replaced the hollow of the joint, the part up in on the edge of the skull, with this plastic or nylon piece that's held in place by these screws. And then the ball part of the joint was replaced with titanium on both sides. So here you can see she's only, she wasn't able to close her teeth together when biting. Her back teeth would hit first. And now the lower jaw is reoriented and she can touch her front teeth together. And it also improves the profile. See, no chin here. Here's a chin. If you think that you have had this problem, I'm starting to look at this with Dr. Dinesh Khanna, who is a well-known scleroderma rheumatologist at University of Michigan. And we're interested in finding out what people's experiences have been with this particular issue. So shoot me an email and I will share that with Dr. Khanna. I don't know, we just started talking about it a week ago. I don't know where we're going to go with that. Find a dentist. Many dentists have training to work with patients who have autoimmunity. Students at many dental schools rotate through special care clinics. Oral medicine and public health are specialties within dentistry that have extensive training on working with people who have autoimmunity or autoimmune disease. And general practice residencies and advanced education in general dentistry are residencies at dental schools and hospitals that offer additional training after dental school, including how to take care of complex patients with complex medical issues. There's Special Care in Dentistry Association, scdaonline.org. By the way, I'll have this on the last slide so you can copy it down. On their website, they have a Find a Dentist section. It's really hard to find a special care dentist in southeastern Florida for some reason, but other than that, people seem to have good luck with that. And You can always call your local dental school, call their oral medicine department and ask for a recommendation. And they either may have someone within the school or they may know dentists outside the school that they're associated with. And most tertiary care hospitals, large hospitals, so I'm thinking like, if you're in Atlanta, Grady Memorial Hospital, or if you're in New York, Mount Sinai or Bellevue Hospital, these hospitals have these general practice residencies or AEGDs. Did I miss something? Oh, and also you can email me and I'll help you find somebody. So dental summary, tell your dentist you have scleroderma and how it affects you. Don't hide it. Annual X-ray imaging is very important for prevention. Bring your list of medications and your list of physicians. Schedule appointments for the time of day that's best for you. The dental office staff may say, oh, Dr. Leader doesn't like doing root canals at 7 o'clock at night. He only does simple things like cleanings. But when you say, well, I have this chronic illness and I can't come in earlier in the day, I need my beauty sleep. My staff would understand. Hopefully your doctor's staff would understand, and your doctor. Physical therapy, do your exercises right before your appointment. Bring gloves and a blanket and let your dental staff know if air conditioning is a problem for you, because many of us will not know about Raynaud's and how getting air conditioning blown on you can be uncomfortable. But also remember, we're having to wear more PPE than we ever did before, and that's probably not going to change. So we're hot, we're sweaty, we need the air conditioning. Bring your gloves and your blanket. But if you were to come to my office, we would make the office nice and cool and then turn off the AC while you are there so that you don't have the wind blowing on you. And remember, orthodontics and dental implants are okay. Medical team, diagnose and treat xerostomia, diagnose and treat GERD aggressively, watch for side effects of medications that may affect oral health, prescribe physical and occupational therapy, refer patients to dentists, provide medication lists and recommendations. Here's the brochure that I wrote for the Scleroderma Foundation. You can download it from the website free. Here's my contact information. Here's the website for special care in dentistry. Here's how to sign up for the SPIN cohort, which I hope you all will. And I am now open for questions. And I hope I didn't go too long.
Oh, no, that was perfect, Dr. Leader. Thank you very much for that informative presentation. It does look like the attendees have taken the opportunity to ask a few questions. And
Great.
we do have a national office staff, Angel Soto, Programs and Services Associate, here to facilitate that segment. Angel?
Thank you, Carrie, and thank you, Dr. Leader, for that wonderful presentation.
Thank you.
We do have some questions, so I'll just get right to it. Our first question here is, are there any at-home remedies or just anything that we can do at home to help with receding gums or help us strengthen our teeth?
So yes. So some people who have scleroderma have receding gums because the tissue around the mouth is getting tight and it's actually pulling the tissue away from the gums. That's something that you need professional help for, because a gum specialist needs to go in and do what we call releasing incisions to loosen up that pull. But if you're using a soft toothbrush or one of the electric toothbrushes that I recommended and using it gently, not pushing hard, that helps prevent your gums from receding faster. Using the fluoride treatments at home, asking your dentist for a prescription for the prescription strength fluoride toothpaste is very helpful. Avoiding acidic foods, avoiding sugary foods, these are all very important. And let's see, and definitely flossing. any way that you can clean in between your teeth is a benefit.
Thank you.
Mhm.
Next question is, I've avoided going to the dentist because of the risk of COVID-19 in our area. Do you think that it's okay to keep prolonging my appointments when I generally go to the dentist every 3 months?
So I am so glad that this question came up, because you can imagine that in my group of friends, in my family, in my school, this is a big conversation. I'm on Facebook groups where all we do is talk about oral health and COVID-19. So the CDC has pointed out that even though dentists and dental hygienists are very much at risk for contracting COVID-19, they don't have any evidence that COVID-19 has been transmitted within a dental practice yet. And I'm going to knock on wood for that. If you've noticed, when you go to a dentist or when you go anywhere now, there's someone taking your temperature, there's someone asking you questions, there is extra PPE, there's plexiglass everywhere. Many dentists have installed air cleaners or made our air handling equipment push air through the office faster, which is another issue if you have Raynaud's. At my school, we now have in our clinics 6 air changes per hour, complete air changes in these enormous clinics, 6 every hour. It's very expensive to do that. We are slowing down how many appointments we're seeing. There is no one waiting in a waiting room anymore. Waiting rooms are passé. You wait outside, maybe in your car, or if you walk there, maybe just on the street, and you wait for them to contact you on your phone to come in, so that you're not sitting in the waiting room with other people. When I've talked with patients in my school clinic, so this is a school clinic, it's a big clinic with a lot of people in it, although we've sharply decreased how many people are in it at any one time now. Some patients have commented to me that they feel safer sitting in our clinic being cared for by our students than they do walking down the street. So yes, COVID-19 is a concern. It's a big concern. It's a concern of mine. I have this conversation with my parents who are in assisted living all the time. It's a concern of every dentist, every dental hygienist, but we have always been very good with infection control. You've probably noticed that from previous dental appointments. And this is just, for COVID-19, it's just a little bit more of what we were already doing. And it's actually making some of us dentists feel even better about what we're doing than before, because before we felt like maybe wearing this kind of mask was cutting corners a bit. Now we're only wearing the best kind of mask. And one other thing, some dentists found that some of these N95 masks, they have a square valve on the front. It's a one-way valve, so that when you inhale, everything is filtered, but when you exhale, your exhalation goes straight out through that valve. And it was kind of actually funny. The American Dental Association sent us all a bunch of these N95 masks with those valves at first, and right away people were sending them back, and the American Dental Association took them all back and sent us appropriate masks. But those N95 masks are very good if you're working in a dusty environment, like if you're a mason putting up cutting stone, you want to have a mask like that. Anyway, I think that you're okay going to the dentist, but you have to feel comfortable. So do what you think is right.
Perfect. I'm sure that's definitely reassuring to the community to know all those precautions that are in place. The next question is it true that we should avoid getting root canals because bacteria in the mouth can go to the gut and cause complications?
So first of all, if you need a root canal, you have a lot of bacteria inside that tooth that you need to get out. And I understand what you're saying about bacteria from the mouth getting places that you don't want it. Now, first of all, getting to the gut is absolutely not a problem. Your gut can take all the bacteria, we can send it. The problem is if it goes to your heart. And for most people, that's not an issue. For some people, it is an issue. And when dentists are asking you all of those health questions, all those annoying health questions, a lot of them are geared to helping us make sure that you're not one of those patients. Root canal treatment is a very safe treatment. The things that we're hearing that are negative about root canal treatment go back to research that was popularized in the 1930s and has since been repeatedly disproven, but it sounds, it sort of sounds right when you say it, and it has a ring of truth to it, so it's very scary, and I think that's what makes it popular, sort of like the zombie apocalypse. But if you need a root canal, you should have a root canal. I've never needed one. My parents have had root canal treatment. I would have them get root canal treatment again. Actually, I did have my mother get root canal treatment again on one tooth because the first time it was starting to fail. And remember, when you're having a root canal done, we're using a rubber dam to prevent bacteria from inside your mouth from getting back in the tooth and reinfecting the tooth. So that's why you have the little metal clip on the tooth, and that's why you have the sheet of rubber over the tooth, because we want to keep everything inside the tooth very sterile, and we are sterilizing the inside of your tooth when we do root canal treatment.
Thank you. So we're about 10 minutes past the hour, so out of respect for your time and that of the participants, I'm just going to ask one last question. The last question is, I suffer from bad breath, and this started after a few procedures, including a bridge that was put in last year. My dentist says that this is not the cause. Is there any other condition that could be causing this?
So most of the time when you have bad breath, it's not from something in your mouth, although it can be if you have gum disease. So if you have a bridge, I don't know if this is a fixed bridge that's attached to teeth or if it's one that you take out, but either way, if you're getting food stuck around it, of course you have to keep that clean. And if you have gum disease, that has a particular odor to it. But most of the time, when you feel that you are having bad breath, it's from something else, and it could be from diet. So, for example, when you eat onions and then you brush your teeth so that you have no onion in your mouth anymore, you still have this odor of onion because the onion odor, chemicals from the onion, get into your bloodstream, go to your lungs, there's air exchange, and when you exhale, you're smelling onion. Same thing with garlic. If you have diabetes, if you're having a problem with your diabetes and it's not under control, that can give your breath an odor. Certain infections can give your breath an odor. So if your dentist is sure that there is nothing dentally related that's causing this mouth odor, the next person to check with would be your physician.
Great. Thank you, Angel, for facilitating the question and
Thank you.
answer segment. All great questions. Dr. Leader, any parting comments as we wrap up today's session?
Well, I just want everyone to know that my relationship with you does not stop here. I get questions from people associated with the Scleroderma Foundation fairly regularly. You are welcome to email me at david.leader@tufts.edu. And if I can't answer your question, I might be able to find someone who can answer it for you. Same thing, if you're having trouble finding a dentist on your own, I might be able to help you there. I do hope that you'll try first. And if you have a dentist who you like, who the only problem is that they don't know about scleroderma, I am happy to get on the phone with them, and in 20 minutes we can have them up to speed so that they can know everything I know. That's it. Thank you very much.
Wonderful. In closing, I would like to thank Dr. Leader for sharing your time, expertise, and your email address with the folks joining us today for information. Thank you for all of our attendees that logged in or dialed in today. Special thanks to our Diamine national sponsors, Actelion Pharmaceuticals US and Boehringer Ingelheim, and our corporate sponsors, Corbus Pharmaceuticals. We'll be hosting the summer series webinars weekly. Next Wednesday, August 27th, we will have makeup artist Vivian Stevens hosting a workshop on skincare and the art of camouflage makeup. Please stay connected with us through our website, scleroderma.org, and our social media outlets to stay informed on our virtual university patient education summer series, as well as our great chapter virtual events happening now across the country. As we all take that one last peek out Dr. Leader's window, we really appreciate you dialing in today, and that concludes today's webinar. Be well and have a nice day. Take care.
Let's see.